All right, excellent. Good afternoon, everyone, and welcome to Citywide Medical Grand Rounds today, April 18th, 2024. Next slide, please. We're pleased to have St. Joseph Healthcare Hamilton as the host site today. Next slide, please. And we'll start with a land acknowledgement today. We acknowledge that St. Joseph's Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. And we'll bring up the next slide. So once again, welcome to everyone. And I'm very excited to have our presenter here today, Dr. Meagan Guay. She's going to be presenting to us on providing an update in migraine pathophysiology and CGRP targeted therapies. She's an assistant professor in neurology at McMaster University. And I'm going to hand things over to my co-host today, Dr. Marvin Chum, who is our head of service for neurology at St. Joe's. And he's going to tell us a bit more about Dr. Guay before she starts her presentation today.
Thank you, Dr. Berhosik. So it's my great pleasure to introduce Dr. Meagan Guay. She's one of our new neurologists here at St. Joseph's with subspecialty expertise in headache disorders. Dr. Guay completed her residency here at McMaster University, where she also serves as chief resident. After that, she completed a fellowship in headache at the University of Toronto's Centre for Headache at Women's College. She currently has a very active headache practice here at St. Joseph's, alongside being an assistant professor of neurology at McMaster University. Amidst all of that, she's also an active member of the Canadian Headache Society and has several publications in the area of headache medicine in the Canadian Journal of Neurological Sciences, the Journal of Pediatric Neurology, and the Canadian Journal of General Internal Medicine. Without further ado, I'm going to hand over the mic to Dr. Guay, who's going to be telling us about some cutting-edge knowledge and treatment in the world of migraine.
Thank you so much for that introduction, Dr. Chum. I'm happy to be here today, and thank you for the invitation. So yes, happy to be giving an update on migraine pathophysiology and specifically with a focus on our new CGRP targeted therapies. These are my disclosures and conflicts of interest here. Okay, so the objectives of this talk is to understand the underlying pathophysiology and mechanism of migraine and migraine aura, discuss factors contributing to the development of migraine, and review advances in migraine management with a focus on CGRP targeted treatments. So for the first part of this talk, I'll be focusing on migraine pathophysiology. So first and foremost, and if there's anything that I would like taken away from this talk, is that migraine is more than just a headache. Migraine is a complex, often debilitating and life-altering neurologic condition characterized by recurrent episodes of headache associated with other multisystemic symptoms. We have newer studies now showing us that even outside of the headaches themselves, patients with migraine have changes in sensory processing and brain structure compared to those patients without migraine. This leads to an interictal state even between migraine attacks. Just a little bit of migraine in history. So migraine has been around for many, many years. The earliest documentation was in 1550 BC with the well-known Herbers Caprius. They discussed headaches in keeping with migraine. Treatments at that time included bloodletting, catfish skull, perch bone, and stag's horn. It was Hippocrates who first scientifically documented his clinical observations of migraine, describing episodes of a bright light in the right eye, followed by the onset of severe pain in the head, discussing obviously a migraine aura. He hypothesized that it was due to vapors rising from the stomach into the head that was causing migraine. In the 17th century, Thomas Willis founded the vascular theory of migraine. He hypothesized that migraine was due to vasodilatation of blood vessels within the brain. In 1898, Mobius felt that, and this is the most likely theory today that we believe is true. He stated that parenchyma is master and circulation is servant, stating that migraine was not only due to dysfunction of blood vessels, but widespread brain dysfunction. And that's what we understand to be the cause of migraine today. In regards to migraine epidemiology, in 2016, almost 3 billion individuals worldwide were estimated to have a headache disorder. Of this, over 1 billion were migraine. Migraine takes second place for responsibility of years lived with disability worldwide, behind that of only lower back pain. Worldwide, migraine is estimated to cause at least 45 million years lived with disability worldwide in 2016. And I think it's important to note that this has significantly increased from just 2.8 million years lived with disability in 1990. We know that during their reproductive years, females are 3 times more likely than males to have migraine, and migraine is the top cause of years lived with disability worldwide in females aged 15 to 49. So what causes migraine? And this is a complex question, but I think it's important that we all have a basic understanding of that, because often patients want to know why they're so debilitated by migraine, why have the investigations and the neuroimaging come back normal? And it's nice to be able to give them a bit of an explanation to explain what may be happening. The answer is it's quite complex. It's now widely accepted that migraine is a genetic disorder. However, we also know epigenetic factors play a significant role. So these include environmental factors such as stress and adverse childhood events, changes in barometric pressure, metabolism, diet, and exercise. As well, we know specifically in females that estrogen fluctuations, specifically drops in estrogen, can be triggers for migraine, which is why we see migraine severity and frequency changing throughout different stages in women's lives, from the onset of menstruation to pregnancy, as well as menopause. It's likely that all of these factors come together, leading to hypothalamic activation, alteration of thalamocortical circuits, and brain connectivity. This leads to activation of the trigeminal cervical complex in the brainstem, ultimately leading to cortical spreading depression and the release of vasoactive neuropeptides such as CGRP and PCAP38. A little bit more about migraine genetics, because again, I think it helps us to understand a little bit the spectrum of the disease. So there's 38 gene polymorphisms identified to be a risk for patients developing migraine. In addition to this, we have newer studies that show the number of genetic polymorphisms inherited, or the migraine polygenic risk score, does play a role in the way that this disorder presents in patients. So patients with higher polygenic risk scores or more genetic polymorphisms are those patients who typically develop migraine at a younger age, may have childhood migraine variants refractory to multiple treatments, baseline light sensitivity and sound sensitivity. And this is in comparison to those patients who may have a low polygenic risk score, who are easily treated with a triptan a few times a month or a first-line preventative. So it just helps us to understand why the spectrum of the disease is so broad. In addition to this, I always like to talk a little bit about adverse childhood events and migraine. We're learning more and more about how childhood trauma can affect brain development. Adverse childhood events, or ACEs, are defined as traumatic events occurring between the age of 0 to 18 years old. However, we do know that the brain continues to develop into the mid to late 20s, so likely it extends beyond 18 years. There was a survey completed in the United States in 2010 that found that 58% of patients with migraine have a history of ACE. However, this is likely underrepresented because in this survey, they only included ACEs of abuse and neglect, whereas there is a broad range of ACEs, and it's not just limited to those things. We also know that the types of ACEs make a difference. So threat ACEs, living in an unsafe environment, bullying in school, any form of abuse, may lead to disruptions in the HPA axis and amygdala functioning. Whereas deprivation ACEs, so neglect, parental divorce, death of a close family member, may lead to reduced synaptic dendritic branches and decreased synaptic connections. And I think this is an important risk factor to screen for in all patients. It helps them understand their disease a little bit better. Many do have good insight. And in addition to this, it helps us to guide targeted treatments such as cognitive behavioral therapy, mindfulness, and trauma therapy. So changing gears a little bit to discuss neuroimaging in migraine. And this is something that comes up a lot. You have a patient in your clinic who has migraine. Sometimes it's very severe and debilitating. At what point is imaging indicated, and do we have any evidence or guidelines around this? The answer is we do. In 2018, the American Headache Society came out with guidelines based on consensus criteria. So there is level A evidence that it is not necessary to do neuroimaging in patients with headaches consistent of migraine who have a normal neurologic examination, no atypical features or red flags present. There's level C evidence that neuroimaging may be considered in patients who have more atypical presentations. So for example, unusual or prolonged aura, increased frequency, severity, or change in their migraines, first or worst migraine. If they have motor manifestations, confusion, side-locked headache, or late-life migraine headaches, these are indications that you can consider neuroimaging at that time. But for your basic bread of butter migraine with no headache red flags, neuroimaging is not necessarily indicated in all of these patients. Talking a little bit about the phases of migraine. When I used to do talks on migraine during residency and fellowship a few years ago, we typically talked about the 4 phases of migraine. The prodrome, which is the hours to days leading up to a migraine, where the patient may be more fatigued, a little bit more light and sound sensitive. Sometimes they have yawning, neck pain. Then we would talk about the aura, which is experienced by only about 20 to 30% of patients with migraine. The headache phase itself, which by definition lasts 4 to 72 hours. And then the postdrome, or kind of the migraine hangover, where they're more fatigued, foggy, not back to baseline. That lasts about 24 to 48 hours. However, there's growing recognition that migraine is more of a cyclic disorder. So patients cycle between 5 phases, and many patients continue to experience symptoms between the migraine attacks, referred to as the interictal phase. These symptoms include allodynia, hypersensitivity, ongoing photophobia, phonophobia, vestibular and visual disturbances. And there are newer studies that do show changes, like I said, in the structure and baseline connectivity in patients with migraine compared to those of normal controls. So just to talk briefly about the migraine aura. So cortical spreading depression is the physiologic basis for migraine aura. This is characterized by a wave of glial depolarization, which spreads over the cortex at a rate of 2 to 4 millimeters per minute. And that explains why we often, or patients often describe the migraine aura or the scintillating scotoma, as you can see in this picture, kind of moving slowly across the visual field. Or if they have a sensory aura, it kind of moves slowly down the arm at about a rate of 2 to 4 millimeters per minute, matching the rate of cortical spreading depression. This leads to transmembrane ion fluxes and release of vasoactive neuropeptides, CGRP, which I'll talk about more, as well as PCAP38. This wave is followed by hyperemia or increased blood flow, followed by a more prolonged wave of oligemia or decreased blood flow. So this question comes up a lot. What is the risk of stroke in patients with migraine? We know that people with migraine are at a 2 times higher risk of ischemic stroke and a 1.5 times higher risk of hemorrhagic stroke. In addition to this, we also have newer studies that tell us aura does increase this risk further, but the number of auras per month or per week do make a difference. In those patients with infrequent aura, less than once per month, patients are at a 2-fold increased risk. But if they have more frequent aura, more than once per week, they're at a 4-fold increased risk. This risk further increases when you place patients on hormonal contraception. So when you place them on hormonal contraception, if they don't have an aura, you're increasing the risk of stroke 4-fold. And if they do, you're increasing it 6-fold. And this increased risk is higher in those who are under the age of 45 and smokers. And like I said, if they do have aura. This risk is greatest within the first year of use. So what's the bottom line or for hormonal contraception in migraine? Obviously, every patient is different and it needs to be taken on an individual basis. But in general, if the patients have migraine without aura, I'm typically okay with them being on hormonal birth control or estrogen-containing birth control. I prefer them to be on monophasic, low-dose estrogen formulations to decrease those fluctuations in estrogen. Sorry about that. In addition to this, it's very important to monitor for new auras or worsening of auras, particularly in the first year of use. If they have migraine with aura, I typically recommend against estrogen-containing birth control. They can consider progesterone-only options, such as the progesterone-only pill, IUD, or the implanton. If required for medical reasons, everything obviously needs to be a discussion about risks and benefits, but again, typically low-dose monophasic, and very carefully monitor for changes in aura or headache when you're starting these patients on estrogen-containing birth control. In addition to this, interestingly, we know that PFO is associated with an increased risk of migraine, over a 3.4-fold increased risk in migraine with aura, and a 2.5 increased risk in migraine without aura. Pathophysiology is unclear, but we wonder whether it's due to microemboli due to shunting. There have been studies that do not show closure of PFO being helpful for reducing migraine attacks. However, there are studies showing that daily clopidogrel can be an effective preventative. So if I have patients with frequent or atypical migraine auras, I will often send them for echocardiogram with bubble study. And if they do have PFO, I have started patients on Plavix. Aspirin likely would be similar. We just don't have the studies in it. And this can lead to a significant reduction in migraine aura. In addition to this, migraine aura is more common in patients with vasculopathies and autoimmune conditions. So I do sometimes screen my patients with, again, atypical or prolonged aura for these underlying disorders. Okay, so talking a little bit about the headache phase, and I think understanding the headache phase is important because it helps us understand how to use our acute migraine treatments. So we think that migraine begins peripherally when pain neurons that innervate the dura mater are activated. This leads to the release of the vasoactive neuropeptides, which I talked about, and initiates signaling along the trigeminal vascular pathway. And this leads to something called peripheral sensitization, which causes the characteristic throbbing pain in migraine. We know that if left untreated after 30 to 60 minutes, central sensitization occurs. Central sensitization occurs when projections from the trigeminal ganglion travel to the brainstem to the trigeminal cervical complex, or the TCC. And this is what I like to call the pain switch. Once this pain switch is activated, pain signals are sent to higher cortical sensory areas, and you get something called central sensitization. And that leads to the classic cutaneous allodynia that patients with migraine describe, where they're having pain touching their head, hair elastics hurt, sunglasses hurt, and they really can't have anyone touching their heads. We also know that repeat activation of this pathway and persistent central sensitization leads to increased risk of developing chronic migraine. So this is why, and I'll go into the acute treatments for migraine, but it's this pathway and the underlying mechanism for migraine, which helps us to understand why it's so important to use acute medications early. So we want to use the acute medications before central sensitization occurs, because that once that pain switch turns on, it's very hard to turn off. And that's why we have patients, or I have patients coming into my office who have had a headache every day for the last 3 months, 4 months, 5 months, sometimes 6 months. Often it's because they've had chronic migraine, they've had central sensitization, that pain switch has turned on. And so this is why I always educate them about treating their headaches hard and fast at onset with their acute medications to try to stop the development or the kind of progression of the migraine, central sensitization, to hopefully decrease the length of time that the migraines last for. Okay. So speaking of treatment, we'll move on to the second part of this talk where I'll review some migraine treatments. So while we do have a lot of exciting advances in migraine therapeutics, it's also very important to note that this isn't the most important thing. I always talk to my patients about the 4 tiers of migraine treatment, with the first and most important tier being lifestyle. Without making changes in lifestyle, it's very, very difficult to treat migraine. So these lifestyle things that I always highlight is keeping a headache diary to identify triggers, eating a regular diet, not skipping meals. As well, we have studies that show morning protein, 12 to 15 grams within an hour of waking, is very helpful for patients with migraine. Regular sleep, so going to bed and waking up at the same time every day and avoiding naps, stress management, exercise, reduction in caffeine, and avoidance of medication overuse, which I'll talk a little bit more in some later slides. But we know that it's these lifestyle factors that really decrease the chances of patients going from episodic migraine, which is less than 15 migraine days per month, to chronic migraine, which is over 15 days per month. So educating patients early about these lifestyle changes before they get overly severe is very, very important to try to prevent progression of the disease. In addition to this, we know nutraceuticals are helpful. We have evidence for magnesium citrate, riboflavin, coenzyme Q10, and vitamin D. So I typically recommend all of my patients start on these supplements. It's only then that we go into acute treatments, and I discuss acute treatments with patients. I say, these are the medications you take when you have a headache and you want it to go away. And then we have preventative treatment. So how do we stop you from getting the headaches altogether? So I'd like to talk a little bit, as we're going into the new therapies, about migraine, the history of migraine targeted treatments. So the first migraine targeted treatment were the ergots, which were developed in the 1920s. It took 70 years for a second targeted medication, sumatriptan, to be approved in Europe, which was then followed by the development and approval of 6 more triptans. In 2010, another huge advance came when onabotulinum toxin was approved for treatment of chronic migraine. Throughout the 1990s and early 2000s, there was lots of ongoing research about the role of CGRP in migraine. However, it wasn't for a number of years, 2018, when our first CGRP monoclonal antibody, Anishinabe, was approved for the treatment of episodic and chronic migraine. In 2019, lasmiditan was also approved for acute treatment of migraine. Unfortunately, we don't have this available in Canada, and as far as I know, I don't believe it will be coming anytime soon. Also in 2019, a little bit later that year, the FDA approved our first CGRP receptor antagonist, Ubrogepant, for the acute treatment of migraine, and that's been subsequently followed by the approval of 3 more gepants, which I'll talk more about. So this table here summarizes our evidence-based acute migraine treatment. So you can see under level A, we have acetaminophen, aspirin, ibuprofen, naproxen, and diclofenac. We also have our triptans, which I'm going to talk about more on the next slide. We have a combination of triptan and naproxen called Suvex, and there is also level A evidence for acetaminophen, aspirin, caffeine, which I don't typically use. We don't use dihydroglutamine nasal spray frequently anymore because of the side effects. Likely additions or updates will be the addition of the acute gepant, so ubrogepant, rimegepant, and zimegepant. So in regards to choosing triptans, not all triptans were created equal. We have 7 triptans in total, and you can see the routes of administration here. So sumatriptan, we do have the option for subcutaneous injection as well as a nasal spray. Zomatriptan, we also have a nasal spray available. We have wafers, so disintegrating tablets for zomatriptan and rizatriptan, and then all of them have a pill formulation. So in my patients who wake up with migraine, so we know that if patients wake with migraine, it's probably been brewing for a while and probably central sensitization has already occurred. So we really want a fast-acting triptan, so sumatriptan subcutaneous, the nasal spray formulation, or zomatriptan nasal spray can be helpful. If they have nausea and vomiting, if they're going to vomit up their medications, the injectable or nasal spray is better, as well as the wafer. For menstrual migraine, we use our longer-acting triptans, so naratriptan and frovatriptan. Sumatriptan also has evidence in menstrual migraine. For adolescents in Canada, almotriptan is approved for over 12, and in the US, zomatriptan and sumatriptan as well, and rizatriptan is actually approved for patients over 6. I would say if I think it's important to have kind of a go-to triptan. So my go-to triptan, and for anyone out there who's treating migraine, my go-to triptan first line is often almotriptan. And the reason is that it often has less side effects compared to the other triptans. So it's kind of an easy one to start. You can also split the tablet if they are having side effects. So that's kind of my go-to one, unless I have a reason for trying the nasal spray or the injection first. But I also want to spend some time touching on the triptan side effects and contraindications. So there are some patients who can have significant side effects to triptans. So this would be fatigue, dizziness, nausea, paresthesias. You can also get something called triptan sensitization, which is a sensation of chest pain, fatigue. As I mentioned, almotriptan is less likely to cause that. Some patients also have severe side effects such as MI, arrhythmia, or vasospasm, CVA, hypertension, and there is a very small, risk of serotonin syndrome, typically less than 0.03% per year, but it is something we keep in mind, but is very, very unlikely to occur with the triptans. For these reasons, triptans are contraindicated in patients with coronary artery disease, prismental angina, high-risk cardiovascular disease, uncontrolled hypertension, or basilar and hemiplegic migraine. And this is important to highlight because we do not think that gepants have the same contraindications or vasoactive activity. Therefore, this opens up treatment options to patients that we typically previously would have been wanting to avoid triptans in. So it gives us another medication for some of these patients who are at higher risk of cardiovascular or cerebrovascular disease. And here is just a highlight of some of the evidence-based preventive migraine therapy. It's not an exhaustive list, but I included the ones that we most commonly use. So as you can see here, the older treatments we typically borrowed from other medication families. So we borrowed metoprolol, propranolol, and candastarin from our cardiac medications, topiramate and valproate from our antiepileptics, amitriptyline and venlafaxine from our mood medications. But we have now our new targeted migraine therapies, which I'm going to talk about. The likely upgrades for the preventatives, which you can see here, will be the CGRP monoclonal antibodies, as well as the CGRP antagonists approved for preventative treatment, so atogepant and rimegepant. Candastarin will likely be moved up from level C to level B or A. And I actually do like candastarin as one of my first line migraine medications, as it often has less side effects than others. Memantine and melatonin will likely be added, as well as the addition of the neuromodulation devices. So we do have trigeminal nerve stimulators and vagal nerve stimulators as well. So what are some indications for starting preventative treatment in patients? So obviously, if the attacks are significantly interfering with their daily routines, despite acute treatment, if they're having more than 4 monthly migraine or headache days, because we know that patients who have over 4 migraine days per month, they're at an increased risk of developing chronic migraine. So we want to catch them early before they progress. If they have contraindication, failure, or adverse events to acute treatments, and especially if they have medication overuse, because this medication overuse is one huge risk factor for worsening of migraine, development of chronic migraine, and chronic daily headache. So this is defined as taking medications such as ergots, triptans, or opioids more than 10 days per month for 3 months, or our simple analgesics such as our NSAIDs, acetaminophen, more than 15 days per month. So really educating these patients early on about the concept of medication overuse and rebound headache is extremely important. Many of them don't know, and they think they have a headache, I'm going to take a Tylenol, but they don't actually realize that it can be detrimental. So catching these patients early, starting them on a preventative, and trying to reduce the acute medications is extremely important. Just talking a little bit about onabotulinum toxin for chronic migraine. So it has level A evidence for chronic migraine. And just remember, it's not episodic. So often I get referrals for Botox in patients with, 8 or 9 headache days per month. And unfortunately, these patients won't get approval. To have chronic migraine, you need to have at least 15 headache days per month, 8 of which have associated migrainous features. So the mechanism of action, as we all know or may know, is that onabotulinum toxin acts presynaptically by cleaving SNAP25. And this prevents the exocytosis of pro-inflammatory neurotransmitters such as CGRP, substance P, glutamate from the presynaptic terminal. It also, over time, leads to decreased insertion of pain-sensitive ion channels into the membranes of nociceptive neurons. And this just shows where I do the injections for Botox. There's a series of 31 injections with a total of 155 units of Botox. I typically do these every 12 weeks, And I do always say to patients that you can take up to 3 rounds of injections, so up to 9 months actually, to be able to assess if we're going to have benefit from the onabotulinum toxin injections. So moving on a little bit to our CGRP medication. So what is CGRP? So CGRP stands for calcitonin gene-related peptides. It's released from the presynaptic terminals of the trigeminal nerve and binds to the receptors on the vasculature of the dura mater. So we know that during migraine attacks, CGRP serum levels are elevated. We've also done, not we, but they have also done studies that show that CGRP infusion triggers migraine-like headaches in patients with migraine. So they would actually infuse CGRP into migraine patients, and it would cause a significant migraine headache. Triptans act by reducing CGRP levels concurrent with pain relief. And selective antagonists to CGRP and its receptors effectively treat migraine. So this chart summarizes our CGRP targeted therapies. I'm going to focus today more on the gepants because these have just become available in Canada in the last year. But we do have as well 4 CGRP monoclonal antibodies. So these are monthly subcutaneous injections and do have very good evidence and efficacy in chronic and episodic migraine. The new one that we had come out just last year is epitizumab, which is actually an IV infusion formulation given every 3 months. And then there are 4 gepants that are approved in the United States. So we have 3 of them that are in Canada, and actually Rimidgepant has just became available in Canada. I got my hands on the first samples yesterday, so I'm excited to try it. So your Brojepant, which we have available, is a PO acute formulation, so acute migraine treatment. Rimegepant in the United States is approved both for acute and preventative. So in the States, they dose it every second day as a preventative with an option for topping up if ongoing headache. In Canada right now, we just have it approved for acute treatment. So we'll be using it similarly to Ubrogepant, but hopefully we'll ultimately get approval to use it also as a preventative. Zimidgepant is a nasal spray. It's recently been approved by the FDA, but is not yet available in Canada. And then atogepant is a preventative. So it's a daily oral preventative medication for migraine. So I wanted to spend a little bit of time talking about these new medications because they're great options for us. They're another tool in our toolbox, and they're something that I hope not only neurologists and headache specialists will be using, but also family physicians, internal medicine physicians as well. So first of all, let's talk about Ubrogepant, which is our acute treatment. So ACHIEVE-1 and ACHIEVE-2 were the pivotal trials for atogepant. Primary outcomes looked at pain freedom at 2 hours and impact on most bothersome symptoms, which is photophobia, phonophobia, and nausea. Both studies showed a significant difference in pain freedom for both the Ubrogepant 50 milligram and 100 milligram dose. Similarly, both studies showed a significant difference in the absence of most bothersome symptoms at 2 hours. In addition to this, we have the results of a recent Ubrogepant prodrome trial. So this study shows that Ubrogepant taken during the migraine prodrome, and remember that's the period of time up to 2 days before a migraine attack where they have subtle symptoms, so subtle light sensitivity, sound sensitivity, yawning, food cravings, neck pain. And if you take Ubrogepant during this phase, you're less likely to develop a headache at all. And if you do, it's less likely to be moderate to severe in intensity. And this has been practice changing for a lot of the headache neurologists because we used to recognize the symptoms of the prodrome, but we didn't really have anything to treat it with because we were worried about medication overuse and what if they're wrong. But Ubrogepant, it's been studied that it can be taken safely up to 16 days per month, so almost up to every other day. It's not likely to lead to rebound headache or medication overuse headache, and in fact could have some preventative capabilities. So we're not too worried about telling our patients if you think you might be getting one, if you think you're having your prodrome symptoms, just try taking the Ubrogepant. We think the earlier you take it, the better. The most common adverse events reported were nausea, fatigue, dry mouth, and dizziness, but overall I have to say these are much better tolerated than the triptans. No serious adverse events were reported. And importantly, the presence of cardiovascular risk factors did not appear to impact the rate of treatment emergent adverse events. We are also studies were carefully looking at the liver enzymes of patients on gepants because the first generation did show elevated liver enzymes. However, the newer generation does not show any signs of that, and there is no signal of hepatotoxicity, which is reassuring. So moving on to talk a little bit about Rimegepant, and remember this is only approved for acute treatment in Canada. And as I said, it's only just become available, so it's exciting to be able to have this new option for treatment. So results from the phase 3 trials of Rimegepant show that the 75 milligram dose has superiority compared to placebo for both pain freedom at 2 hours and freedom from most bothersome symptoms. In respect to additional endpoints, Rimegepant was shown to have statistically significant efficacy starting at 60 minutes post-dose. And at 120 minutes post-dose, 59% of patients had pain relief. They weren't actually in this study, they did not release the numbers for less than 120 minutes, but definitely at 2 hours post-dose, almost 60% of patients had improvement in their headache, and there was a statistically significant difference from placebo. Just talking about a little bit of practicality in using these. So Rimegepant is a single one-time daily dose of 75 milligrams. No dose adjustment is needed for mild, moderate, or severe renal impairment, but it should be avoided in end-stage renal disease. And no dose adjustment is required for mild or moderate hepatic impairment, but should be avoided in severe. Ubrogepant comes in both 50 or 100 milligram doses. I typically start with 100 milligrams unless I have another reason not to. You can give a second dose of ubrogepant in 2 hours if needed, and I often do encourage patients to do that. It's typically avoided in patients with end-stage renal disease, and in patients with severe renal or hepatic impairment, the dose should be decreased to 50 milligrams. And then the recommended doses for patients over 65 is 50 milligrams. I'm not going to go into this slide too much, but I just wanted to draw your attention to this because it is important. All GPANs are metabolized through the CYP3A4 and the P-glycoprotein pathway. So there is definitely drug-drug interactions that we need to be aware of, and that I'm always very careful of when I'm prescribing it. So there is a need to dose adjust when you're using moderate to weak CYP inhibitors, and contraindicated in patients with strong CYP3A4 inhibitors. So always check for drug-drug interactions, check the product monograph, and can check with pharmacy as well to ensure that patients are not on any other medications that they should not be on before prescribing this. Okay, and then finally, just talking briefly on atogepant, which is our preventative treatment. So important to note that in Canada, atogepant has only been approved for episodic migraine. So remember, less than 15 headache days per month. In the States, it's approved for both episodic and chronic. So it's likely effective for both. However, the issue becomes getting coverage for this medication in those patients with chronic migraine. Right now, hopefully that will change in the future. So ADVANCE was the pivotal trial for atogepant, and it showed that this once daily oral medication had a rapid onset of action with efficacy within 1 to 4 weeks, which is actually much quicker than a lot of our old non-targeted migraine medications, which I always tell my patients can take up to 3 to 4 months to see benefit. We see that there was this relief was prolonged up to 12 weeks, which was as far as the study went to. In addition to this, we can see that the atogepant treatment resulted in a 50% or greater reduction in monthly migraine days in 60% of the patients on the 60 milligram dose. There is also a small number of super responders, which we do see sometimes in CGRP targeted treatments, who have 100% reduction in headache days. There have also been indirect comparison studies showing that the percentage of responders were similar between atogepant and our monthly injectables, so the CGRP monoclonal antibodies. Emerging long-term safety data is reassuring from a hepatic and cardiac point of view, similar to ubrogepant. The main adverse events leading to discontinuation are constipation, nausea, fatigue, and decreased appetite. And I will say that this can cause significant fatigue and nausea and constipation, and I have had to stop a couple of my patients to take them off this medication because of these intolerable side effects. In regards to using these practically, I typically start at the 60 milligram dose. You have to dose adjust to either 30 or 10 milligrams, and again in patients with renal impairment, or if they're on weak or moderate CYP3A4 inhibitors. Should be avoided in patients on strong CYP3A4 inhibitors, end-stage renal disease, severe hepatic impairment. None of the GPANs have been studied in pregnancy and lactation, and they're not well studied in patients over 65, so need to be used with caution. I consider atogepant when patients have side effects or failures to other migraine preventatives. They prefer oral options. And again, the half-life of atogepant is shorter than the CGRP monoclonal antibodies. And actually for those patients, those young females planning pregnancy, they can't be on the injectables for 6 months before trying to conceive. So this sometimes can be used as a bridge. When they can't be on the injectables for 6 months, you can start atogepant. And as long as they stop 2 to 4 months, 2 to 4 weeks before trying to conceive, this is a good option for them. And then once they want to start trying, you just stop the medication. So that's another advantage for our patients of childbearing age who aren't sure when they want to start planning a family, or if it may be soon. We often would start considering atogepant for them. And then just one last slide looking into the future. So this is an exciting time for migraine treatments. There's tons of new medications being developed. We're getting new ones, like I said, in Canada every day. So another treatment options that's currently being started is looking for blockers of PACAP38, which I mentioned a few times earlier in the talk. So we have evidence for the role of PACAP38 having a similar pathophysiology and the mechanism of migraine similar to CGRP. So PACAP38 binds 3 receptors, PAC1, VPAC1, and VPAC2. There were trials for a PAC1 receptor antibody, so blocking the receptor, and these failed in phase 2, likely because PACAP38 was then just binding the other 2 receptors. But now we have a drug that is an antibody against PACAP38 itself, so the ligand, which has had positive phase 2 trials and is now entering phase 3. So lots of things to look forward to in the future. So in conclusion, migraine is a common disorder leading to significant morbidity and years lived with a disability worldwide. CGRP targeted migraine therapies provide promising alternative acute and preventative treatment options for migraine. Research into the underlying genetics, pathophysiology, and treatment of migraine is ongoing with the possibility for new targeted treatments in the future. And these are my references, and then I'm happy to take any questions.
Fantastic. Thank you so much, Dr. Guy, for that extremely clear and knowledgeable presentation. We're so grateful to have your expertise here to serve patients in our region. So we have a couple of questions in the Q&A, and I'll encourage anyone who hasn't yet, if they've got a question, please feel free to enter your question into the Q&A section on Zoom or to raise a hand. And I'll just read out the first question that we have here. It's from Dr. Mark Crowther. Hi, and thanks for great rounds. I apologize if you mentioned this and I missed it, but do you use Cambia? I hear great things about it, but tastes awful. Just plain old diclofenac work.
Yes, I do. I use Cambia all the time. I wasn't trying to not mention brand names, but yeah, it was listed under level A for diclofenac, and I use Cambia. It's usually, so my go-to medications when I have a patient coming in with migraine, my go-to first line acute, I give them Cambia, a sample of Cambia, because I have samples, and I give them almotriptan. And I tell them to take them together if it's a bad headache. It tastes a bit like peppermint. So some people actually don't mind the taste and others really don't like it. The one thing I'll say is that sometimes people are mixing it with too much water. So you mix it with water, and you really should only be mixing it with about 30 mils. So then it really should just go back in one quick shot. But if you're mixing it with too much water and trying to chug it with a lot of water, it's not going to taste good and it's not going to work as well. So yes, I do like Cambia if it's taken properly.
Excellent. Thanks for that response and the practical tips for anybody who's trying to optimize. I'm going to hand things over to Dr. Chum. There's another question in the chat. And I think there was a hand up, although it's disappeared. So I'm going to look into that.
Indeed, there is a second question. What is the cost per day for a CGRP therapy?
Yes, so they are expensive. So the G-PANs, so I don't actually know about Rimegepant yet, but I've heard they're all similar. The G-PANs are about $15 to $20 per tablet. So it's quite expensive, especially if you're on a Atogepant, which is you're taking every day. But Atogepant is covered by ODSP, Ontario Works. So I do apply for EAP approval for my patients less than 25 or over 65, or if they have ODSP. Your Brogepant, unfortunately, is not covered. So some patients pay out of pocket, some is covered by their insurance company. And then for the CGRP monoclonals, the injectables once a month, it's about $500 to $700 a month. So it's quite expensive if it's not covered. But again, EAP covers a ton of them, most of them. So that's also an option.
That's really interesting. And there was one additional question that popped up in chat. Dr. Marquez writes, for patients with migraine, if they have white matter lesions, is that another contraindication for OCP? Is progesterone contraception better in such cases, and are they safe?
Yeah, so no, that's fair. So there's definitely no, the answer I guess is no, the short answer. So definitely increased white matter lesions are more common in patients with migraine. Again, we don't know exactly why. Does it have more to do with increased microemboli, maybe increased chance of having a PFO? But they are proportionally increased again in patients with migraine aura and frequent migraine aura. So if they have a lot of migraine lesions and they have frequent migraine aura, then it's a definite no. But if they have no aura, even if they have white matter lesions, I would still be saying it's okay to use the OCP, again with caution, and monitoring for any worsening of the migraine or the migraine aura.
Thank you. At the moment, it looks like we have one more question. We've got Dr. Mitch Levine with a question that he'll ask. Go ahead, Mitch.
Okay, yeah, thank you. That was great talk. It was really good, comprehensive review, and new stuff. I have a question about the CGRP products or drugs. It seemed like, yes, they work better than placebo, but it's caught me as kind of disappointing that when you saw the percentage that was no headache in 2 hours was still only about 50%, which means still half of the patients don't get any benefit.
Yes, absolutely. So the thing I will say from my experience, I only have experience right now with Japan. I will hopefully gain some quickly with Japan, is that they don't have that same kick. They definitely don't. So triptans, Cambia have that quick onset. Japan, again, it works, but I find it doesn't work as well, especially if you're taking it late. So the thing with Japan is I'm encouraging them to take it as early as possible to try to almost prevent the headache. But yes, I agree, especially if you take it too late, it's not going to be beneficial. What I do and what some migraine specialists do is I tell them to take, and there's no interactions here, I tell them to take Japan and the Cambia. And then that way the Cambia gives them the kick, and then the Japan sometimes sustains them over a longer period of time. And I will say too, if they take, let's say they take the Japan and then in an hour or 2 hours they still have a headache, then they can take their triptan or their Cambia. So sometimes it's about combining these things a little bit. So that's something else I also use. And I do agree it's not that great but for our patients who are limited, or if we've tried everything else for, it's another option. And some have really good effect, some don't.
Mm-hmm. Thanks.
Yeah.
Thank you so much for that. We're just noticing that there was a follow-up from Dr. Marquez in the chat to that initial question and response. So if there is no aura, would you still investigate PFO if there are white matter lesions?
If there's a high burden, yes. But again, it depends on how and what I'd be looking for other causes, right? Are these true, I don't want to just attribute them to migraine. Would I be investigating if there's any type of vasculitis, something else going on? But if they do have a high burden of white matter changes and there's no other cause through other workup that's been identified, I would consider an echo, yes.
Great. I have one question, and then I'm going to hand it to Dr. Chum, who has let me know that he's also got a question. I also see Dr. Holbrook's hand raised. So Marvin, if you don't mind, when I hand it over, you can oversee that. So, as I'm looking at this, there's really dramatic practice changes over the past few decades. Are you able, I know we're kind of adult medical grand rounds, but are you able to speak to, what we're seeing in terms of early data, or what we're expecting in terms of disease course for young people who are getting migraine early on? Presumably really the holy grail of migraine is where you can get at that, get at the migraines early so it doesn't evolve into that chronic, as you had highlighted so nicely. Mm-hmm. What do we know so far about how that's going and what that should be looking like for the current generation of youth with migraine? Yeah,
absolutely. So I will say for the CGRP monoclonal antibodies, so I wouldn't say the older, but the injectable ones, we haven't seen as much disease modification. In fact, we actually see that they wear off over time. But we do wonder if new ones, the GPANs, so the CGRP receptor antagonists, may have disease modifying, especially because, for example, for ubrogepant, which we're using as acute treatment, we actually think possibly it could have some, we're using as acute, it could have some preventative. So there is a question about whether these possibly could be disease modifying. So that's the goal. And then a lot of the goal for stopping progression is going to be not just medications and treatments, but really education early on about medication overuse, lifestyle things as well. But there is some promise, I would say, for the GPANs that they may be.
I think Dr. Holbrook has her hand up, and then after that, there's also a question in the Q&A. So Dr. Holbrook, would you?
Thanks very much. I had a similar question and comment related to Dr. Levine, and I think the burden of illness, still needs a lot more work. But my specific question for Dr. Guay, I may have missed this, and I apologize if I did. I got distracted for a minute by another email. But the long-term prognosis in migraine, I wondered where the experts stand, because I'm still left with the residual notion, which we've had for a long time, that migraine means more vascular disease, which over the long term adds up to dementia. Is that an actual realistic concern? Do we have good data on that?
So for as far as I know, I don't have great data, or have not. It's not something I've learned about, that patients with migraine are at a higher risk of developing dementia later on. I know that there have been some studies that have looked into the burden of white matter, because we've been talking about that, and whether that increases the risk of stroke, and those have been negative. So overall, I don't know, as far as I know, there's no significant correlation. Now, the question is, some of the medications we're using to treat it, could that lead to dementia? So for example, tricyclic antidepressants, when we're using them in patients over 60, that definitely, there's some correlation studies there for increasing the risk of dementia in that way. So, possibly that is a bit of a correlation, but for migraine itself, I don't believe that there's any positive studies for that.
Right. And I would suggest as a clinical pharmacologist that the tricyclic data is reverse causation. That's extremely biased data. So it's an association, not causation. So I would doubt that's a factor. Okay, thank you.
And there was another question from the Q&A. Is it a perception, or is there data that amitriptyline has less adverse effects?
Oh, there's data. Yes, there's definitely data. It's been shown to have the lowest. Sorry, I will say the triptans with the three triptans with the least side effects are the longer acting ones, first of all. So frovatriptan and naratriptan, those ones were designed specifically to have less side effects. However, those ones are longer acting and don't have the same efficacy as I would say amitriptyline does. So I do try those medications. If they have side effects to amitriptyline, I move on to my longer acting frovatriptan and naratriptan. But the third one there is amitriptyline, and it typically acts quicker than the frovatriptan and the naratriptan, which, while it has those have a longer half-life, they don't have the same acute response that amitriptyline does.
Right. And one other question from me as well. You mentioned earlier medication overuse headaches, and that's certainly something I think a lot of the residents can come across during their inpatient sort of rounding and admitted patients, and sort of the need to be on sort of preventative therapy. I've seen mixed evidence on both sides in terms of transitioning from traditional OTC analgesics to preventative medications. Is there a wean? Is there a cross titration? Do you pull turkey, start one another? What's your typical practice?
Yeah, so typically I try to bridge my patients. So the goal is so for example, if they're overusing a triptan, I try to introduce a longer acting NSAID such as a naproxen. And often I do a 2-week bridging course of naproxen, specifically if they're overusing triptans, Tylenol, or Advil. I say you're going to take naproxen twice a day, morning and night. I add a stomach protector if I need to, for 7 to 14 days. Stop taking your other acute medications at that time. And then we're going to also start a preventative. also if they're overusing naproxen or NSAIDs, you can do a 5-day bridging course with those longer acting triptans like naratriptan and frovatriptan. So no, I don't typically stop cold turkey. I don't think you're going to have great benefit, but it's about education, doing the bridging course, starting a preventative, and then a lot of times just making them aware, because I have patients who have been taking Tylenol every day for 5 years, and I talk to them about rebound headache and medication overuse headache, and they have no idea. So I think education is really key. And a lot of them come back to me the next visit and they're like, yeah, I stopped taking the Tylenol, I stopped taking the Advil. And sometimes I do tell them it can get worse at the start because you're going to have a rebound headache because you're not taking anything. And then ultimately over time, the goal is that we get them under better control. Mm-hmm.
All right, well, that brings us right to the end of our hour today. I'd like to, again, thank you so much, Dr. Guay, for the wonderful presentation. And I'll remind all of our attendees that this is recorded and it will be posted on the McMaster Department of Medicine YouTube channel. Thank you, Dr. Chum, for co-hosting and co-moderating with me today. And I'll invite everyone to return for medical grand rounds next week, April 25th at the same time, and it will be HHS-hosted Chief Medical Resident rounds. I wish you all a wonderful rest of your day and week ahead, and we'll see you back next week. Take care.
Thank you. Bye, everyone.